Good morning. My name is Abby Church, and I am the Homeless Health Infectious Disease Manager. I have Jesse Van Hoosier and Abigail Kornberger, who are the Homeless Health Infectious Disease Outreach Analysts. Abigail is the Northern Analyst, and Jesse is the Southern Analyst. Today, we will be discussing the COVID-19 Congregate Living Settings Guidance. We have developed this webinar to include considerations, risk assessment tools, protection and prevention tools, testing and isolation guidelines, and we have included several tools for you to utilize as you wish. This guidance was developed to be used as a tool for you, so please pick and choose the items that you believe will be useful for you in your duties. And now I'm going to send it over to Jesse.
Thanks, Abby. Before we begin, we want to make sure that we go over a few important considerations. Firstly, and most importantly, we want to acknowledge the amazing work that shelters and homeless services organizations completed throughout the COVID-19 pandemic. The last few years have seen no shortage of challenges, and the sheer level of determination and adaptation from agencies has been incredibly impressive. Secondly, with regards to the COVID-19 guidance document, we want to be clear that you are encouraged to implement as many feasible measures as possible for your agency to protect residents and staff. Being such a large document and addressing a broad spectrum of agencies, it is not possible for every measure to be appropriate for every single agency. Please apply as much as is feasible for you. This guidance can be useful in establishing and updating your agency's COVID-19 practices and policies, in reducing administrative strain, and in supporting any specific health initiatives within your agency. I'm going to pass it over now to Abby to address the next few slides.
The COVID-19 Guidelines Congregate Living Settings combines the most current Centers for Disease Control and Prevention guidance for mitigating COVID-19 spread in congregate living settings. Because of the close proximity of residents in homeless shelters, the risk of COVID-19 transmission is higher in these settings compared to the general population. A higher prevalence of underlying or pre-existing health conditions produces an increased risk of severe outcome of a COVID-19 infection among this population. Transmission mitigation efforts will look differently in a congregate living setting than measures we would take at home or in a healthcare setting. The following COVID-19 webinar and guidance will provide staff a framework to assess their facility's specific risk of COVID-19 spread, define everyday prevention measures and enhanced prevention measures, update quarantine and isolation guidance, and additional resources. These additional resources, including cleaning, sanitizing, disinfecting guides, an everyday symptom screening tool, and situational walkthrough guides. We will touch on all of these items in this webinar. It is understood that facilities may not be able to apply enhanced COVID-19 prevention strategies due to resource constraints, population characteristics, and available planning space. Facilities are encouraged to implement as many feasible measures as possible to increase the population's level of protection against COVID-19 infection. The HHID team makes an active call to update the COVID-19 Guidelines Congregate Living Settings Guidance as the CDC continues to update recommended procedures in these sites. These active updates aim to diminish the administrative strain on agencies to update such guidelines. Next, we are going to discuss risk assessment tools. Facilities can consider factors that would indicate heightened risk, including a high volume of outside visitors, poor ventilation, areas where individuals sleep close together, such as shared sleeping spaces and/or dorms, residents' ability to adhere to COVID-19 prevention measures, example, ability to mask, social distance, consenting to a rapid test, etc. in the facility are more likely to develop severe COVID-19. This can be true if residents are considered high risk and/or have limited access to healthcare. High-risk persons can be described as persons with pre-existing or underlying conditions. The full list of conditions will be included in the guidance document. Active COVID-19 spread occurring in the facility. Facilities are highly encouraged to use the CDC COVID data tracker to assess risk within their community. This dashboard allows individuals to view COVID-19 hospital admissions, deaths, emergency department visits, and test positivity by county. This live data tracker is updated twice weekly with the most current geographic data. It should be noted that this dashboard does not reflect positive at-home rapid tests conducted in the community. The CDC recommends diagnostic testing for everyday prevention measures and routine testing during periods of high COVID-19 community levels, or if resources are available. These efforts act as surveillance measures for assuming additional facility risk. Diagnostic testing. Performing rapid antigen testing for symptomatic residents during daily symptom screening or at intake. Routine testing, performing rapid COVID-19 testing every 3 to 7 days for residents. And now, Abigail will tell you about transition measures. Prevention measures. So sorry. Abigail will tell you about prevention measures.
Thank you. As we touched on in the last slide, individual facility risk assessment and CDC COVID-19 data tracker data play a role in which level of prevention measures are recommended. Nearly every prevention measure, examples being testing, isolation, and PPE usage, includes both an everyday prevention measure and an enhanced prevention measure. Everyday prevention measures for COVID-19 are recommended to be in place at all times, regardless of COVID-19 community levels. Enhanced prevention measures are recommended in addition to everyday prevention measures when COVID-19 community levels are high, anytime there is active transmission within a facility, and or 3 or more active cases within 14 days have been identified within the facility. We can define active transmission as being a case of COVID-19 identified by contact tracing that has been spread from an ill resident to a healthy resident directly. We will cover contact tracing guidelines in a later slide. Rapid implementation of an emergency policy aims to mitigate the extent of the COVID-19 transmission and the risk of severe outcomes among staff and residents. Next, we are going to move into our first prevention measure category, PPE usage. Personal protective equipment, PPE usage, is a transmission mitigation effort to protect both the staff and residents from COVID-19 transmission. PPE can include, but is not limited to, masks, respirators, gloves, and hand sanitizer. Everyday prevention measures surrounding PPE include maintaining a stock of masks, respirators, gloves, hand sanitizer, and other items for the facility. These measures include offering high-quality masks and respirators to all staff, regardless of illness. All staff conducting COVID-19 testing or direct care to ill residents in isolation are recommended to be fitted with a KN95 or an N95 and gloves. Indoor masking, regardless of vaccination status, among those considered to be high risk of developing a severe case of COVID-19 is also encouraged. Enhanced prevention measures surrounding PPE include all of the everyday prevention measures. However, it is encouraged that during these periods, agencies require universal masking regardless of vaccination status. As a reminder, enhanced prevention measures are to be implemented based on facility-specific risk, if community levels are high, and or resources are available for implementation. Let's discuss 3 categories of transmission and the measures your agency can take to mitigate these. The SARS-CoV-2 virus that causes a COVID-19 infection can spread through airborne, contact, and droplet transmission. These transmission and prevention measures will cover these 3 bases of spread in their mitigation efforts. First, ventilation improvement. Agencies are encouraged to ensure HVAC systems are functioning properly and group events are held outdoors when possible. Enhanced prevention measures include testing ventilation options in advance and improving ventilation circulation as much as possible. The guidance document will include tips on how agencies can improve ventilation within their facility. Second, physical distancing. Agency staff are encouraged to create 3 to 6 foot distance in congregate settings where possible. This can include additional distance between beds, empty chairs between residents during meals where able to, and social distancing when standing in lines. Enhanced prevention measure periods, staff may consider reducing movement and contact between different areas of the facility. Lastly, frequent sanitization. It is recommended that agencies complete standard infection control sanitizing at all times. Items include hands, bed materials, shared surfaces, frequently touched surfaces, all high traffic areas, and all shared items. In enhanced prevention measure periods, more frequent daily sanitization practices may be necessary, and prompt sanitization after each resident uses a shared item or a surface as well. Both intake screening and daily symptom screening measures aim to identify early cases of COVID-19 infection before transmission. Agencies are encouraged to conduct temperature checks and complete the National Healthcare for the Homeless Council NHCHC symptom screening tool with residents as an everyday prevention measure for daily and intake to the facility. The NHCHC screening tool is a 1-minute survey about past feelings of fever, cough, muscle aches, and sore throat. We will discuss the NHCHC symptom survey further on a later slide. If warranted, due to risk factors previously discussed, agencies may begin providing rapid antigen testing to all new residents among intake, regardless of the criteria outlined in the NHCHC symptom screening tool. As an enhanced prevention measure, staff may begin conducting rapid antigen testing every 3 to 7 days, alongside the daily symptom screening measures in place. Next, we are going to touch on a few testing guidelines. Routine testing can help identify infections early, which is especially important for curbing the magnitude of transmission. Everyday prevention measures include conducting rapid antigen tests for all residents and staff who have been exposed to a person with a confirmed case of COVID-19 or who are symptomatic. We will discuss post-exposure guidance and the definitions of a close contact on the next slide. Enhanced prevention measures include more frequent rapid antigen testing every 3 to 7 days for residents and staff. If you are rationing supplies during periods of high COVID community level, staff are encouraged to prioritize those considered to be high risk of developing a severe case of COVID-19 for testing. Contact elicitation is a voluntary yet crucial part of case interviewing. Staff wearing a proper PPE, which is KN95 or N95 mask, may ask residents around them if anyone fits the definition of a close contact. A close contact can be defined as an individual who was less than 6 feet away from the infected person for a cumulative total of 15 minutes or more over a 24-hour period within 2 days prior to the onset of symptoms or 2 days before the positive specimen collection date. During periods of high COVID-19 community levels, facilities may begin identifying exposed persons to anticipate possible spread among the facility before a contact tracing interview has taken place. Post-exposure guidance. After a resident has tested positive for COVID-19 and the recent contacts have been established, agencies are encouraged to move exposed contacts into quarantine where possible, test residents who have been exposed at 5 full days after the exposure, or sooner if they develop symptoms. Want to consider the first day of exposure to be day 0. Highly encourage exposed residents to mask while indoors for 10 full days after exposure, and that's regardless of vaccination status or individual risk of severe COVID-19. You may note that there are not enhanced prevention measures for post-exposure guidance. Testing earlier than 5 full days after exposure or before the development of symptoms can result in a false negative result. Next, Abby is going to cover the recommended everyday and enhanced prevention measures for isolation and a few additional considerations when choosing an isolation space.
We will now cover a few general isolation guidelines and then move into a few special considerations on the next slide. Everyday prevention measures. All persons should continue to mask for 10 full days, even if they receive a negative test result resulting in their isolation period ending before day 10. Isolate staff, volunteers, and residents who have tested positive for COVID-19 away from other residents for 10 days since symptoms first appeared or from the date of collection or test. A molecular laboratory base or antigen test may be used to determine if the isolation period can be shortened to 7 days. However, it should be noted that a rapid test requires 2 negative results before this period can be shortened. We will cover this in a later quick guide. The resident staff member symptoms must also be improving. fever-free for 24 hours, and they were not hospitalized and are not considered a high-risk individual. Further guidance on ending the isolation period early will be discussed in the following slides. Enhanced prevention measures. During crisis level operations, large outbreaks, severe shortages of staffing or space, short reductions to the standard isolation period may be made. Facilities are encouraged to contact their local health department to discuss appropriate measures to meet needs while maximizing infection control. COVID-19 is a respiratory illness that can spread when an infected individual breathes out droplets and small particles that contain the SARS-CoV-2 virus. Isolation measures should aim to eliminate or diminish the spread of these droplets and particles between residents who have tested positive for COVID-19 and those who have not. The isolation period for congregate living settings is longer than the duration recommended for the general public. Risk of widespread transmission and high prevalence of underlying medical conditions associated with the development of severe COVID-19 is the reason. Create distance between individuals in isolation and the community. Arrange beds so that individuals lie head to toe relative to one another. Create temporary physical barriers between beds using sheets, curtains, or accordion walls in large shared rooms. Consider whether a room shares direct ventilation with another before using the space for isolation. If multiple residents have tested positive, these residents can isolate together in the same area. Therefore, suspected and confirmed cases should not be housed within the same space. Staff are encouraged to refer to the least ideal isolation quick guide when choosing isolation spaces or rooms that are faced with space planning and or resource constraints. We will cover the ideal to least ideal isolation quick guide in a later slide. And now Jesse will tell you about cleaning versus sanitizing versus disinfecting.
These next few slides show some various quick guides and graphics that exist in the COVID-19 guidance document. Here, we see a simplified visual of the difference between cleaning, sanitizing, and disinfecting. Cleaning removes most types of harmful germs, viruses, bacteria, parasites, or fungi from surfaces. Sanitizer will remove the remaining germs on surfaces after they have been cleaned, and disinfectant can kill harmful germs that remain on surfaces even further after cleaning. Disinfectant can further reduce the risk of spreading disease. Always follow manufacturer safety guidelines when using chemical disinfectants. Always clean surfaces first before disinfecting and sanitizing. Impurities like dirt will act as a barrier and inhibit the sanitizer or disinfectant from being able to work effectively. Next, we have a symptom screening tool from the National Healthcare for the Homeless Council to help in identifying whether masking and quarantine or isolation may be necessary interventions. Staff are encouraged to take this tool and modify the workflow to fit available staff numbers and potential resource constraints. If an individual answers yes to any of the questions 1 through 7, and has a temperature equal to or higher than 37.8 Celsius or 100 degrees Fahrenheit, or if yes to any of the questions 1 through 4 without a fever, masking and isolation is advised if possible. Additionally, if an individual has a temperature higher than 37.8 Celsius or 100 Fahrenheit with no other symptoms, quarantine is advised. Here, we show good practices for respiratory hygiene broken down for staff and residents. Additionally, we show hand hygiene practices, the frequency they should be performed, and the best methods and practices for that. Regarding respiratory hygiene, staff should provide tissues and no-touch receptacles for their disposal. Additionally, providing access to hand sanitizer and soap is a crucial step. Encouraging residents to cover their mouth and nose when coughing or sneezing is also important. Hand hygiene should be utilized regularly throughout the day, such as after using the restroom, before eating, and when contact is made with shared items of someone in isolation, quarantine, or who is suspected of COVID-19 positivity. Next, I'm going to pass it over to Abigail to discuss a few decision tree quick guides to help determine how to respond to specific situations.
Thank you. Over the course of the next 2 slides, we're going to cover a couple of situational walkthrough tools for agencies' staff to visualize the following processes. The first walkthrough guide represents a recommended daily or intake screening symptom screening process. If a resident passes the NHCHC symptom screening tool we discussed in slide 15, the resident continues as regularly intended. If a resident fails the symptom screening tool, which may look like a resident responding yes to 1 through 7 with a temperature of 100 degrees or higher, or a resident responds yes to questions 1 through 4 without a high temperature, or a resident presents a fever without other symptoms. A resident who meets those first 2 situations, meaning they are presenting symptoms, it is recommended that the resident wears a mask, moves into isolation, and receives a rapid COVID test immediately. A resident who does not present symptoms outside of a fever is recommended to move into quarantine and test upon further symptom development. Note that quarantine may look like a resident residing within an individual room, either alone or with others who may also have a fever without symptoms. Quarantine space could also be a shared isolation quarantine space. It is recommended that if a shared space is being utilized for isolation and quarantine, that there is distance created between those in isolation and those in quarantine. Agencies are encouraged to utilize accordion walls, sheets, and 6-foot distance to distinguish between these 2 groups. Without proper measures in place, an individual in isolation, meaning they have tested positive for COVID-19, may infect a resident who may not have COVID-19. The second walkthrough guide represents the recommended process in an event a resident tests positive for COVID-19. It is recommended that a resident isolates for 10 days while also wearing a mask. At 5 days isolation, the resident can retest in their isolation period early. If the resident receives a negative viral test, and that would be a laboratory-based test, their symptoms are improving and they have been fever-free for 24 hours, they may shorten their isolation period to 7 days. If at 5 days isolation, the resident receives a negative rapid test, and that would be an at-home test, it is recommended that they retest 48 hours later to confirm the result, but they may also end isolation at 7 days as well. If the test result at 48 hours is positive, it is recommended that the resident continues to isolate until day 10. While they may be able to end isolation, it is recommended that the resident continues to wear a mask through day 10, regardless of that isolation factor. Jesse will now cover our isolation and congregate living settings, ideal to least ideal quick guide.
Thanks, Abigail. A few general tips for isolation measures are to, as we've discussed, create 3 to 6 feet of distance between individuals if able, encourage staff to wear an N95 when providing direct services to ill clients, arranging beds so that they alternate directions head to toe, and if able, creating physical barriers between the beds. This graphic also shows a scale of ideal to least ideal isolation situations. As indicated, the manner in which you isolate can vary by number of individuals who are ill, as well as the physical location and building or buildings of an agency. The graphic shows that the ideal situation for each quantity of ill individual is in green and becomes less ideal as you descend down the column. For example, in a situation where only one individual is ill, the ideal circumstance would be to isolate that individual in a separate room. A less ideal solution is to isolate the ill individual in a shared room with some healthy individuals, and the least ideal scenario would be to isolate in a large shared space. Reiterating what we've already touched on previously, we wanted to highlight a few of the key points from throughout this webinar. First, the continuation of services during health crises is essential. Agencies working with individuals experiencing homelessness should work together to avoid shelter closures or the exclusions of people with symptoms or positive test results from services. Additionally, you can find the full COVID-19 guidance for congregate living settings on the IHCDA website by clicking on the link in the orange bubble. If you have a question about county-specific health trends or concerns, or require local information, you can always contact your local health department. Lastly, a brief reminder about health equity. It's the state in which everyone has a fair and just opportunity to attain their highest level of health, and should be factored in when making any policies in your agency. I'm going to hand it over to Abby for one final slide.
While we know that we have just thrown a lot of information your way, please know that we are here to help you if you need or want it. The HHID Homeless Health Infectious Disease email address is on screen. If there are any questions, comments, or concerns for the HHID team, please do not hesitate to reach out about this webinar or about any other question that you might have. Thank you so much for your time, and we look forward to assisting you.